Oh, maybe that's the question.
Good morning, everyone. It's with great pleasure to have Dr. Rosalind Juergens with us today at Grand Rounds of Oncology at Queens. Dr. Juergens received her medical degree from Georgetown University in Washington, D.C., completed a fellowship in medical oncology with a focus on upper aerodigestive malignancies at Johns Hopkins. Additionally, she completed her PhD in clinical investigation at the Johns Hopkins Bloomberg School of Public Health. Dr. Juergens' clinical expertise is in lung and esophageal cancer. Her areas of research expertise involve in improving therapeutics and diagnostics in cancer. Her research is focused on developmental therapeutics with a focus on phase 1 and 2 clinical trials. She's past chair of the executive committee of the CCTG Investigational New Drug Committee. She's a highly sought teacher in the field of immunotherapy, has been invited speaker across the world. We enjoyed having her company yesterday at Global Oncology Rounds, and we're happy today to have her present at our Grand Rounds. Thank you.
Thank you guys very much. I'll tip this back so you guys can sort of see me here. Good morning, everybody out in Zoom land, and good morning to everybody here today. It's a privilege to be invited. I haven't spoken in Kingston now since long before the pandemic, so it's nice to be back. So I thought I would talk today on what I consider sort of the hottest thing in lung cancer right now, and it's all about how do we manage these early stage patients? And lung cancer is sort of coming the way of several other malignancies where we're looking at the strategy of how do we sort the sequence of treatments that we give in an effort to try to cure more patients with lung cancer. Okay, here's my disclosures. These are all the folks that I do clinical trials with, et cetera. I never take anybody off, so the list is long. So I've got a few objectives today. One, I'm going to review the current management of early stage resectable non-small cell lung cancer, although that's rapidly changing. I'm going to talk a bit about some perspectives about immunotherapy in the adjuvant setting. I'm then going to talk a little bit about targeted therapy in the adjuvant setting. And then we're going to talk a bit about safety of doing upfront treatment with things like chemotherapy and immunotherapy in both neoadjuvant and perioperative clinical trials. And then I'm going to talk through a few of the pros and cons about the different sequences and things like that and considerations that we take into account when we're thinking about how we should manage patients. So this goes back quite some time. And again, on the backs of people like Francis Shepard, et cetera, the Canadian history here, we really performed the first and best clean adjuvant clinical trial that was called JBR-10. JBR-10 looked at platinum doublet, specifically vinorelbine platinum, in the post-surgical setting for resected lung cancer. Now, lung cancer isn't like breast cancer, et cetera. Our patient population is older. They have more comorbidities. They have more socioeconomic status issues. So doing 10,000 patient clinical trials has never been in the cards for us, like you can see in some of the adjuvant breast studies. So in an effort to try to get the best evidence, they actually performed a very specific type of meta-analysis looking at all the different platinum doublet chemotherapy adjuvant trials, and it was called the LACE meta-analysis. And what's unique about the LACE meta-analysis is it's not a classic meta-analysis like you might have a medical student or resident do with you. This was a meta-analysis where they actually combined all of the individual patient data from the 5 big different trials that had been done at the time so that they could truly look with more granularity about what the benefits were of postoperative adjuvant chemotherapy. And you can see here there is a modest benefit where there's an improvement of about 10% in overall survival with the addition of platinum doublet, and that has been our standard. But like I said, this is not the easiest thing given all sorts of patient issues. So this is actually a publication that came out of the US, and the US is conducting this massive effort right now where they're trying to get surgical patients tissue sent centrally to the NCI, and then patients are divvied into different slots. So if they have a driver mutation, they might be put into the opportunity of having an adjuvant targeted therapy arm, or if they don't have a driver mutation, there were options for adjuvant immunotherapy. That's called the Alchemist trial. But I think this is just stark data. So if you look at how many patients actually get adjuvant chemotherapy, it's 57%. If you actually get cisplatin, which is the gold standard, so carboplatin seems like a reasonable choice, but the one trial that did use carboplatin consistently, actually the survival deteriorated. It went away with time. So it didn't hold like you see with the cisplatin-based thing. So lots of people make choices to use carboplatin instead, and very few people actually finish all of the treatment. So, we need to figure out how we can do better, because you got to remember, these are clinical trial eligible people. So this isn't average Joe who's out there who might be offered adjuvant chemotherapy in the community. And just to speak to that, we just completed a evaluation through the ICES platform. And this is Yu-Chen Lee. He's one of the residents who worked with me. And we went back to look and see, how do we do here in Ontario? And this is a breakdown by stage. So for stage 1B, where it is not necessarily always recommended to give adjuvant chemotherapy, only 8% of Ontarians receive adjuvant chemotherapy in that setting. Stage 2, only about a third of patients, and even stage 3, where the median survival sits in the range of around 20 months, and that's a curative setting, right? Only 50% of those patients receive adjuvant platinum-based chemotherapy. When we looked at rationale for why did these people potentially not receive chemotherapy, you could see that there were factors including age, their Charleston comorbidity index, stage obviously had a factor, and then socioeconomic status, income. So there have been, I have signed out because you're currently signed into another device. Oh, sorry. No worries. Okay, perfect. So there have been 4 big adjuvant immunotherapy clinical trials that have been conducted. That nivolumab trial is part of that Alchemist program. The atezolizumab is IMpower10 that I'm going to talk about. Durvalumab, everyone here should know about. That was BR31, and we're still awaiting the results of that. And the last one was the pembrolizumab adjuvant trial, which was called PEARLS. So I'm going to take you through the data that we know of from those studies. So the first trial that resulted was the IMpower10 trial. Again, got to be careful about which version of staging we are in, because the 8th version of staging sort of cleaned up a bunch of stuff. This is still in the 7th version of staging. So 7th version of staging. So that's why it says stage 1B to 3A, non-small cell lung cancer. There's a caveat, though, that it has to be more than 4 centimeters. We learned that from the JBR10 trial, that tumors that were less than 4 centimeters, there was more toxicity. So the risk benefit didn't wash out for those patients. So you had to have at least a 4 centimeter tumor or any node positivity to participate. They had to have a complete resection. Patients then had to receive at least 1 cycle of cisplatin-based adjuvant chemotherapy with relevant partner. They were then randomized to atezolizumab or best supportive care, so non-placebo controlled. And you can see here, there were subgroups that were looked at by PD-L1. There's some messiness here, I will be honest. They used one PD-L1 assay for stratification and then a different one for their primary endpoint, because their stratification biomarker has not had global uptake. And they looked at different PD-L1 cut points for their analyses. So this is the disease-free survival in the PD-L1 positive patient population that had stage 2 or stage 3A disease. This is their primary endpoint. So their primary endpoint was not the entire intention to treat population. It was the PD-L1 positive, greater than now 5 centimeters or node positive patients. And you can see here, there is a significant improvement in disease-free survival when you compare atezolizumab to best supportive care. The median for best supportive care was sitting at around 3 years, and the median for use of atezolizumab has not yet been reached, with a hazard ratio of 0.66. If we look then at the intention to treat population, so this is PD-L1 any and includes those 4 to 5 centimeter stage 1Bs. You can see here still an improvement in disease-free survival. Again, median for best supportive care is a little bit better because you pick in some early stage patients, 37.2 months. And again, the median has not yet been reached for the atezolizumab group. This has not met statistical significance yet, so that's why this has not yet reached our shores. So I would love to think that we could be smarter about how we choose our patients. I think that's part of the hardest part about talking about adjuvant chemotherapy with patients. I feel a wee bit like an insurance salesperson every time I have to try to sell someone cisplatin in the postoperative setting. These folks have all had thoracotomies. They have soreness along their chest wall. They're probably a bit more short of breath. And the surgeon has told them that they got it all. And here I am trying to convince them that they should take somewhere between 12 and 16 weeks of this platinum-based chemotherapy. I wish we could be smarter and try to figure out, is there a way to actually tell who is cured or not cured? And they don't come with little tattoos on their forehead. And so maybe the next best thing is going to be something like a liquid biopsy. And we're seeing big clinical trials being done, trying to validate that in colorectal cancer. This is the data out of IMpower 10 looking at cell-free DNA. And so you can see on the top, those are the patients who were ctDNA negative. And then the ones on the bottom were ctDNA positive. You can see a wide separation in the curves if someone was ctDNA positive, AKA there is still bits of cancer floating around in their bloodstream. So adding on atezolizumab in that patient population, huge improvement. The trouble is if you look at the ctDNA negative patients, the addition of atezolizumab still offers benefit. So, it doesn't really help me then to decide maybe a ctDNA patient doesn't need versus a ctDNA positive person does need, but this may speak to the savviness of the assay, right? So we need to work better at making that assay more refined. Now, we've just gotten some of the first hints of overall survival out of this trial. So again, this is the primary endpoint, PD-L1 positive stage 2 and 3, and you can see those curves are starting to separate. I have to acknowledge, though, that this has taken quite some time. This is like 3 and 4 years of follow-up, and we still don't have statistical significance when it comes to that overall survival endpoint. So I think we're going to have to be patient here, and I'll talk a little bit more about my thinking around why maybe this is in a moment. So if we actually then look at subgroups, right? And, I spoke at Global Oncology Rounds last night, and we were talking about value-based judgments and how do we choose our winners and leave the losers behind when it comes to systemic therapies. And there's a few things that we have learned from this particular clinical trial. One is we probably should be excluding our driver mutant patients out of this. It doesn't actually look like they did that poorly, but it actually can bite you later if they do progress, and then you need to put them on a targeted therapy because there's significant interactions between many of our targeted therapies and immunotherapy. So you can see here, they eventually started excluding the patients that were enrolled in this trial who had EGFR and ALK. But the other thing they looked at was that biomarker that we use, and it's an imperfect biomarker, but this is the breakdown by PD-L1. And when you actually look at it, the very bottom here, you can see that the patients who were PD-L1 negative, that little endpoint there is actually on the wrong side of 1. If you get to PD-L1 low positive, the point estimate sits right at around 1. And it's really the PD-L1 highly positive patients who seem to benefit. And so off on the right-hand side of the screen is actually the overall survival when you look specifically at those PD-L1 highly positive patients, and you can see significant improvements when you give atezolizumab after adjuvant chemotherapy and surgery. And so interestingly enough, this is the first time I've ever seen it in lung cancer where it wasn't Cadith who said we should only fund this for PD-L1 highly positive patients. Health Canada came in and said, we're only going to give an indication for PD-L1 highly positive. I was really curious to see what exactly they saw. I actually represented all the medical oncologists across the country at Health Canada. And I was like, gosh, they must know something that I don't know because it didn't look that bad. We didn't have this at the time in the public domain. We didn't know that the PD-L1 lows sat with a point estimate just at 1 and the PD-L1 zeros actually were on the wrong side. So I actually think this was a great move on behalf of our regulatory bodies. So fast forward, we actually thought, wow, this all makes sense. It improved everybody, the higher the stage, the more the benefit, the higher the PD-L1, the more the benefit, like everything logically followed what we wanted to see scientifically. And then comes Pearls. Gosh, golly, here we go. So this was the Pearl study, which was done mainly in Europe, but it was a global study. It was run by the EORTC. Basically same entry criteria. So your tumor had to be at least 4 centimeters or node positive. They had to have a complete resection. They had to submit tumor for PD-L1 testing, same cut points, negative, low positive, high positive. They did not require adjuvant chemotherapy. So you had to have a complete resection, good performance status. They said It should be considered for stage 1B. It's strongly recommended for stage 2 and 3, but it was not mandatory. So a proportion of these patients actually never received the gold standard survival improving adjuvant platinum-based chemotherapy. Patients were then randomized. This was a placebo-controlled trial to pembrolizumab versus placebo. So this is a look at the disease-free survival. And again, you can see the curves separate early. You can also see that this was an early peak at this data. So we didn't have quite a long follow-up at the time of this. So they weren't even giving me hazard ratio estimates per se. They were giving me like 18-month survival rates and things like that. But you can see that there was an improvement in those medians. Now, if we look at subgroups from this trial, you can see smokers benefit more, at least current smokers benefit more than anybody else, although there's still benefit in the never smoking population. Again, scratching my head a little bit. So stage 1 benefits less than stage 2, but then stage 3 doesn't benefit as much as those two. Very clear benefit. There's an interaction there that if you received adjuvant chemotherapy, you did better. And actually the hazard ratio again is on the wrong side of the line. If you did not receive adjuvant chemotherapy, less benefit in squamous. And then the PD-L1 comes, and this has really messed with my brain. So the PD-L1 negatives benefit, and you can see the confidence interval just barely crosses 1. PD-L1 low positive, clear benefit, and then the PD-L1 highs are actually worse than the PD-L1 negatives. So I feel like I have more questions than answers out of Pearls. And so this data is relatively recent. So Solange Peters presented at ESMO last year the actual survival curves looking at the different PD-L1 breakpoints. And you can see there's no question. It doesn't look that the PD-L1 highly positive patients benefited particularly much from this treatment. I do not understand why. If you look at the PD-L1 low positives, clear separation, not half bad though, although the curves come up, they stick together, come apart, and then it looks like they come back together again, but the follow-up isn't long enough to make those curves stable at that point. So interestingly enough, even though this data is not nearly as clean, they got an all-comers indication from both the FDA and, believe it or not, from Health Canada. So here was an analysis that was just at ASCO a couple of weeks ago, looking at what that event-free survival looks like for specifically those patients who received adjuvant platinum-based chemotherapy. And you can see those curves are more separated. You can see the medians are now looking to be somewhere in the range of 20-ish months apart. So a significant improvement in event-free survival for those patients who received adjuvant chemotherapy. So once again, our regulatory bodies came in and said, just like with the Empower 10 trial, we're only going to recommend this for further review for PD-L1 highly positive patients. For this trial, they gave it to any PD-L1, but only if you'd received adjuvant chemotherapy, because that's really where the benefit stood. This is their overall survival. Again, it's still quite immature. This is from the publication in Lancet Oncology. You can see it's a heavily censored curve. So we're just going to have to be more patient to see if there's a true overall survival benefit from this treatment. So what do we do with those patients who have targeted options, right? What do we do with our driver mutant population? I had said they were originally not excluded from the trial. So there's patients with EGFR and ALK who made their way into these studies. But I think many of us had a sense that this might not be the right thing to do for this patient population. And we got that confirmation at the ASCO plenary just a couple of weeks ago. It's been a long time since lung cancer was in the plenary, so I was very happy to see us back. This is looking at a specific subgroup of patients with lung cancer who have something called an epidermal growth factor receptor mutation. Depending on where you are in the world, the rates of these EGFR mutations differ. So if you look in Hamilton, we sit at around 10%. If you go out to Vancouver, it's around 30%. Montreal, again, is similar to Hamilton. I think just a more heavily smoking population. If you go to China, Japan, their rates are somewhere in the range of 40, 45%, even certain countries upwards of 50%. So you have to know your patient population. So this is something that can impact people across the globe. Same idea from entry criteria. It was stage 1B, 2, 3A, resected non-small cell lung cancer. These patients then again had the option of adjuvant chemotherapy. It was not mandatory. Patients were then randomized to osimertinib versus placebo. And the plan was for 3 years of targeted therapy treatment in the postoperative setting. So honestly, no different than hormonal treatment in breast cancer, imatinib and GIST, those types of things. This is sort of the path down which we were going. If there's any medical students listening out there, these are massive differences between these survival curves, right? So you can see a dramatic improvement in disease-free survival when we give adjuvant targeted therapy. Now, this looks really impressive. The problem is you've got to look at the treatment you're giving, right? We know platinum is curative. I truly believe immunotherapy is curative. I was not convinced that targeted therapy is actually curative. I think it needs to stay, and I'm not convinced that it actually eradicates things. So while I was impressed at this curve, I really wanted to see what overall survival looked like. And I was worried it was going to be very tricksy because this trial was stopped by the Data Safety Monitoring Board, and they ended up unblinding patients and allowing people to cross over. So I was worried we were never going to see that gold standard that I want from adjuvant trials, which is overall survival. But let's talk a little bit more about disease-free survival, and I'll talk about overall survival. So this is breakdown by stage. Again, these things bring me absolute joy. If you look at disease-free survival for the stage 1Bs, we're now sitting here in a world where we actually are starting to look more like breast cancer, et cetera. Huge improvements across the board. The higher the stage, the bigger the bang for your buck that you get. But the one caution I will give everyone is, I wish we knew who we needed to give this treatment to. And you'd think with a known driver mutation, we should be able to use things like ctDNA to figure out who still has circulating tumor DNA or not. And that, I think, is going to be relevant from a cost effectiveness perspective for both the stage 1Bs and maybe even the stage 2s. But if you look at stage 3As, you can see as soon as that 3-year time point hits, the curve starts to drop and you start to see people starting to relapse when the drug comes off. So the question of the hour is do we treat them all forever? Is anybody with stage 3 EGFR mutated lung cancer cured? And I think these are questions still for us to answer. So here was the big bang that came at ASCO this year. This was the overall survival analysis. Now, again, wonderful things about certain subtypes of lung cancer. You're going to see here that this is a 5-year overall survival rate of 88% versus 78%. And I never thought that I would sit here when I'm looking at stage 1, 2, and 3 lung cancer and having 5-year survival rates that sit in the high 80s. But that is where we are at. So despite the fact that people crossed over, et cetera, these folks do have an overall survival benefit. I'm going to quote a colleague of mine, Normand Blay, who said, the strategy behind this therapy is to keep our patients from getting into trouble. And I think he's absolutely right. We prevent things like brain mets with this drug. We prevent relapses that get people into trouble. And it may or may not truly be curative, but at the end of the day, from a quality of life and a quantity of life perspective, this offers benefit. So if we look at overall survival by stage, this is that same breakdown. Again, I never thought I'd sit here because the normal survival of, for example, stage 1 lung cancer and garden variety lung cancer is at best 70%. Stage 2 sits at around 50-50. Stage 3 sits at around 2/3 or 1/3, excuse me. So if you look at the overall survival, 94 versus 88%, I feel like that's a soft text difference there. Holy crow. Even stage 2, 85% of those folks are alive at 5 years. And you can see the biggest bang for the bucks in those stage 3A patients. So this is Health Canada approved and funded in most provinces across the country. So I talked about that Alchemist study earlier on. We are trying to replicate this mindset in multiple other driver mutant lung cancer populations. So this is just showing you what that schema looks like. So there are patients who have EGFR mutations who are on a trial there. There's patients who have ALK rearrangements who are following onto a trial there. And then that's the ANVIL study below. But it's taking an entire country, the entire weight of the cooperative groups in the US to try to answer some of these questions. So I'm here today, though, to say maybe this isn't our best strategy. And for those of you who have gotten used to treating people who are surgically resectable, so I said I treat lung and esophageal, we stopped treating people in the adjuvant setting with esophageal cancer decades ago. We recognize that an esophagectomy is quite a massive surgery. These patients do not relatively feel well when they're done with that surgery. And so our ability to deliver adjuvant anything in that scenario is very limited. So we flipped things on its head and we started giving patients preoperative treatment, and that significantly improved the chances of those folks being alive. They've done this in rectal cancer. That was actually another plenary at ASCO looking at selective chemorads versus just neoadjuvant chemotherapy in rectal cancer. They do it in high-risk breast cancer. So this isn't a foreign theme unless you're a lung cancer treater. So the first trial that really, I think, stopped us all in our tracks was this one. The simplicity of it is, I think, worthwhile to note. So this is the Checkmate 816 trial. This, again, 7th edition of staging. So you had to be 4 centimeters or greater or node positive to get in. And then patients were randomized to 2 different types of neoadjuvant treatment, 3 cycles of chemotherapy with nivolumab, or just 3 cycles of platinum chemotherapy. Could be carbo, could be cis, multiple partner options. Patients then had radiologic restaging. They had to have surgery within 6 weeks. And then there was the option of adjuvant chemotherapy after the fact. No adjuvant immunotherapy here. So 3 doses of additional immunotherapy in the upfront setting, and that is it. So this is looking at the breakdown by stage. So if you're stage 1B or 2, less benefit in that circumstance. If you were a stage 3A that's resectable, huge benefits in this patient population. So I think this is food for thought as to who should we be selecting to make sure that we're choosing the right patients. And I think it's a no-brainer when you see a doubling of event-free survival in the stage 3 setting, that is a patient population that benefits from this strategy. Now let's look at PD-L1 score. I've talked about PD-L1 scores and their impact in the adjuvant setting. We know that there's an impact in the metastatic setting. What does it look like in the neoadjuvant setting? Again, PD-L1 negative here on the left, really not a lot of benefit there. So we're not selecting particularly well in that group. But if you look at PD-L1 low positive and PD-L1 high positive, again, escalating benefits the more PD-L1 expression you have. So I think, again, no brainer in our patients with low positive or high positive PD-L1 scores. What about histology? Similar improvements across both squamous and non-squamous, maybe a little better in our non-squamous population. Here's the event-free survival by a new endpoint to lung cancer. So I think our breast colleagues are used to thinking about this endpoint of pathologic complete response, but this is a novelty to us. But anyone who works in the neoadjuvant space is familiar with pathologic complete response as an endpoint. So pathologic complete response was determined in this study by an independent group of blinded pathologists. They did not know which treatments these patients had, and they were basically looking, are there any cancer cells in these sections or not? And secondarily, was there a major response or not? So this is breaking patients down by people who had achieved a pathologic complete response versus those who did not achieve a pathologic complete response. Not shockingly, when you have a pathologic complete response, you're going to do well. And that's true whether you got chemotherapy or chemotherapy and immunotherapy. But the number of people who actually achieved a pathologic complete response were 43 in the chemo IO arm and only 4 people with just chemotherapy alone. Pathologic complete responses with just platinum doublet are uncommon. If you look at the patients who did not achieve a pathologic complete response, the event-free survival here actually looks quite similar. This is the 3-year update that was just presented at the European Lung Cancer Conference in April this past year. So this is an update looking at what the overall survival looks like. So I've shown you IMpower 10, I've shown you Pearls, and we're still sitting here twiddling our thumbs with 3, 4, even close to 5 years of follow-up, and we still don't have a statistically significant improvement in overall survival in either of these trials. But this trial, even with 2 years of follow-up and now further confirmed with 3 years of follow-up, shows a significant improvement in overall survival. This was not necessarily planned. They were looking at simple things like pathologic complete response, et cetera. I don't think we necessarily saw this coming with just 3 doses of additional adjuvant immunotherapy or in neoadjuvant immunotherapy. The hazard ratio is 0.62. And again, you can see here that we haven't even reached the medians in either of these arms. So quite an impressive thing. I will say, as somebody who is a patient advocate and works and watches all of these different approvals, this went to CADITH and was recommended. When this trial got picked up by the PCPA, we had agreed on a price within 2 weeks, and the funding recommendation is being picked up by the provinces as we speak. So you can imagine the value of, like, I've never seen a P-coder thing that said, actually, it meets all of our criteria, but we'll still look for a price reduction, which I can appreciate. So here's where I'm going to actually give you pause. I've been very excited about the CheckMate 816 data, but we also have to recognize that I am making a choice to give somebody a treatment that I don't know necessarily if they're going to benefit from. And I am withholding the one thing that actually truly carries curative intent, which is a surgical procedure. And so if we look at the breakdown here of how many people actually got to surgery, 83% got to surgery in the Nivo chemo arm, and only 75% got to surgery in the chemo alone arm. So this is somewhere around 20% of patients didn't get to that curative intent treatment that they were hoping for. And these were all deemed resectable patients at the time of registration. That's a problem, right? That's the thing that keeps you up at night when you take somebody who should have been curative intent and then they don't end up getting that surgical procedure. So one of the updates at ASCO this year was by one of our colleagues out of Montreal, Jonathan Spicer, who's quite influential in the CheckMate 816 trial. And finally, we've gotten what we wanted, which is what happened to those people? What happened to the people who didn't go to the OR? And so you can see here that 27 people in the chemo arm and 19 people in the Nivo chemo arm did not go to surgery for a reason that was not disease progression, okay? And so what happened to these folks? And you can see a breakdown. So in the Nivo chemo, some of them continued on chemotherapy, some of them went to radiation, and then they don't have the data on 5 of them. If you look at the chemo arm, again, a couple got chemo, a large proportion of them got radiation or chemoradiation, and then some of them went on to additional chemoimmunotherapy or immunotherapy alone. So you can see that these patients did end up getting ongoing treatment. They weren't just left out to the wolves, and many of them had what potentially is curative intent options with the addition of radiation. And I will say that this is one thing that I'm very pleased about when it came to what the CADTH recommendation and the CCO guidance on this treatment paradigm looks like. Because I don't know about here in Kingston, but I know in Hamilton, my surgeons are super, super keen about offering neoadjuvant treatment, right? From a surgeon, they're like, maybe it's going to make my surgery easier. Maybe it's going to be able to reduce the amount of lung that I have to resect. You know, there's lots of good reasons to do what I call a proof of biology and start these folks on systemic treatment. The problem is like I said, these things kick you in the gut a little bit if something goes awry. And we were very worried that the surgeons were going to start pushing the envelope on who should be considered for this treatment paradigm. And then if we choose poorly, where we give somebody 3 cycles of chemoimmunotherapy, and they, for whatever reason, don't end up, they don't want surgery, they have now issues that don't allow them to go on to surgery. Luckily, CCO has said, we will let those patients be considered for definitive chemorads followed by immunotherapy with durvalumab as per the Pacific protocol. You just have to ask us first. I am thrilled that they have an open mind because, again, it's very hard on the medical oncologist to have to make or break that decision of, okay, how likely do I think I'm going to get you through the 3 cycles? How likely do I think that you're going to be well enough at the end of that to be able to still get your surgery? And are you going to respond or not? And, you know, how fine of a line is that? And so it does give us some wiggle room that we don't have to feel like we have to be infallible in that decision when we first start. So next, I'm going to talk about Nadim 2. This is the first of the sort of perioperative trials, although I didn't think of it that way until honestly this morning. So Nadim 2 is actually a phase 2 trial done exclusively in Europe. This is now using the 8th edition of staging and only the stage 3 patients. So stage 3A, 3B, patients were randomized to a specific chemotherapy backbone of paclitaxel and carboplatin with nivolumab versus paclitaxel and carboplatin alone, 3 cycles, surgery. They were allowed 6 months of adjuvant nivolumab in the experimental arm. It was observation in the observation arm. So again, if you look at patient flow, I think it speaks a little bit to difference in practice. So I don't know if there's anyone out there listening who's ever actually practiced in Europe, but they have drank the Kool-Aid on this neoadjuvant space long before the rest of the world did. So it's actually a more common practice for people to get induction treatment there. And we know induction offers the same benefit as adjuvant. So we historically have just said surgeons operate, we'll give them treatment after. But Europe has, for lots of different reasons, embraced the idea of neoadjuvant chemotherapy followed by surgery. So if you look here, these are some of our more difficult surgeries, right? These stage 3 patients, but yet despite that, 93% of patients who got Nivo chemo managed to get to the OR. Now, only 70% or 69% with the chemo arm got there. So again, critically important to choose your best therapy up front. This is looking at their pathologic complete response rate. It sat at around 36.8%. It was just shy of 30% in the Checkmate 816 trial. So a significant improvement, both in downstaging as well as pathologic complete response. Here's the progression-free survival. Again, rapid separations in these curves. So you can see that there's a benefit to Nivo chemo versus chemo. And we also have an overall survival benefit as well. So this is now the second study that showed a neoadjuvant approach offered an overall survival benefit. Now, the trouble is I can't find in the literature out there yet how many patients actually got the 6 months of adjuvant immunotherapy or not. So I have no sense of what the impact is. But if you look at the pathologic complete response curves, just like I showed you for Checkmate 816, here they are for Nadim, and you can see whether you got a complete response from chemo IO or a complete response from just chemo alone. Those patients do incredibly well, right? Like you can't have a flatter line than that one. For folks who did not achieve a pathologic complete response, whether you got chemo IO or whether you got chemo alone, no significant difference in their overall survival. Pathologic complete or progression-free survival in that patient population. So I actually did a debate in the US. I was talking about this last night at dinner, and I was asked to come in and talk about the debate was specifically, should we give additional immunotherapy in the postoperative setting to patients who do not achieve a pathologic complete response? Completely data-free zone. And so they brought in the Canadian to defend Checkmate 816, which is 3 doses of immunotherapy and nothing. And they brought Tina Casconi from MD Anderson, who's like led all of these different neoadjuvant, adjuvant trials as the person I was going to debate. And I showed this and I showed 816 and I said, whether you did the 3 cycles and nothing or 3 cycles and possible 6 months, it doesn't look like we're impacting those patients particularly much. And believe it or not, I actually had one of my favorite American medical oncologists come up to me and told me, Roz, loved your debate, but you were wrong. And I was like, damn, like based on what? Because it's not health economics. I can tell you that. So now we have the next perioperative trial. This is the Aegean trial. So slight differences here. Again, similar population, stage 2 to stage 3, resectable lung cancer by the 8th edition of staging. One specific thing in this trial that I haven't seen in any of the others is if you were thought to need a pneumonectomy, you were not allowed to enroll. So if there was a chance that you needed a pneumonectomy, those patients weren't considered for participation in this trial. So it had to be a lobe, a sleeve, or a bilobe. No pneumonectomies allowed. Now they couldn't prevent it at the end of the day, but if the surgeon felt that this was likely going to require a pneumonectomy, they weren't eligible. These folks were then randomized to now 4 cycles of neoadjuvant treatment, platinum doublet with durva versus platinum doublet with placebo. So now we're starting to say, well, gosh, they always gave 4 cycles of adjuvant. Maybe we should harmonize this to 4 cycles of neoadjuvant. And then patients went on to surgery, and then it was durvalumab or placebo in the adjuvant setting for a year. So Nadim 2, 6 months. This is a year. So this is the event-free survival that was presented by John Haymack at AACR. And you can see, again, an improvement in the different landmark analyses here, where the placebo arm had a median event-free survival of just over 2 years, and the median had not yet been reached on the durvalumab arm. But this is an incredibly early peak, for goodness sakes, right? The median follow-up on this trial was less than a year. And so I don't know if you can see in the audience or if you can see on Zoom, but those curves, it's not your eyeballs that make these curves look fuzzy, it's the amount of censoring in them. So this was very early days at looking at this data, and I'm looking forward to it being more mature. They did not bother to show us overall survival as part of this analysis. This is the subgroup analysis for this trial. And again, PDL1 at the very bottom makes sense. So negative patients still benefit, but not as much as the low positives and definitely not as much as the high positives. So that makes sense. Again, a little bit of wonkiness here if you look at stage. So the stage 2s, wide confidence interval, but the point estimate is in the realm of benefit. stage 3As, which are generally smaller tumors with mediastinal nodes, or bigger tumors with hilar nodes. Those clearly benefit. But if you look at the stage 3Bs, so these are bigger tumors with mediastinal involvement, again, the point estimate comes back a bit, which made me scratch my head a bit, because again, you'd think that these are the patients who need it. But at the end of the day, I think we need to pick our winners. And my question is should those patients actually have ever been considered for a neoadjuvant approach? Should these folks actually be considered for our standard of care for folks like this, which is chemotherapy and radiation followed by adjuvant immunotherapy? This is now the look at pathologic complete response. It sits around 17%, maybe a little bit lower than some of the other studies, but within the realm of statistical difference. Now, one thing I also will highlight is we've gotten smarter with time. So if you look at 816, it doesn't tell you exactly how these surgical specimens had to be sectioned and what the exact criteria were for the pathologist. It just says it was an independent blinded review by pathology. Nadim 2 didn't have a lot of details on it. But as soon as you start seeing Aegean, and I'm going to talk about another trial here in a minute, we actually got together as a global community through the International Association for the Study of Lung Cancer and set up criteria for how should these specimens be evaluated in the resection space. How should you quantify pathologic complete response? I do want to give a shout out to one of your own, Tricia Cottrell, that you guys recruited from Hopkins and is now a pathologist here. She has been an instrumental part in evolving our thinking around how these specimens should be handled so that we can see reproducibility across the trials. So I think, you do have to take things with a grain of salt, but this was using the IASLC guidance around how the specimen should be handled and how PathCR should be called. So I think that's our expectation moving forward. So this again looks at treatment delivery. And again, we all have to pause. Lots of people were able to complete the treatment. So 85% of patients completed all 4 cycles. Again, if you look at how many people got to surgery, still sits at around 75, 77%. Most of them had a complete resection. How many people actually started the adjuvant? Only 2/3, right? People aren't as well after surgery. And so it's not as easy as it may seem. Again, this trial is super early in its peak. So most people still were actually on that year of adjuvant treatment. A quarter of them were still on treatment. But again, look here, almost 20%, 18 to 19% of patients had to discontinue for some reason. So these are not agents without their own toxicity. So let's move on to the trial that was presented at ASCO. This is the Keynote 671 trial. So again, now this is the 8th edition of staging. So stage 2, 3A, and 3B, just like the Aegean trial. Patients were then randomized 1-to-1 to platinum and a partner, either gemcitabine or pemetrexed with pembrolizumab versus gemcitabine, pemetrexed, cisplatin with placebo. So again, a placebo-controlled trial. Patients went on to surgery and then adjuvant, pembrolizumab or placebo for a year. So very similar breakdown. Here's event-free survival, very consistent. So here we are. This is the 4th trial I've shown you. Significant improvements in event-free survival. So you can see here the hazard ratio of 0.58, many zeros in front of that 1 on the p-value here. The median on placebo arm was 17 months and not reached on the investigational arm. Here's the first hints of overall survival. Hazard ratio here of 0.73, p-value 0.02. Still early days. Again, huge amounts of censoring. So we haven't had enough events to really speak to what the overall survival of this is going to look like. But it's something that we're quite excited to see. This was more mature data. So this was 2 years of follow-up versus not quite a 1-year follow-up from Aegean. So like I said, the 1-year follow-up folks didn't even show us overall survival. They gave us a peak showing that these curves are separating, which is consistent with the other neoadjuvant trials. If we look at pathologic complete response, again, 18%, similar to the 17%. They also use that ISLAC specimen handling and pathologic complete response guidance. So these trials are consistent, 18% for the chemo IO and only 4% for placebo chemo, and major pathologic response of about 30% of patients. Here's that same breakdown that I showed you with 816 and Nadim for this trial. So this is again pathologic complete response on the top. You can see the Pembro folks do a wee bit better than the people who achieve a pathologic complete response with chemo. But this is the first trial we've got that actually shows any separation of those curves in people who did not achieve a pathologic complete response. So this is the first time that that little earwig has gotten into my brain thinking, oh, maybe they were right. Maybe ROS isn't right. And maybe we should be giving these folks additional immunotherapy. But we don't have randomized trials. And I don't know how we're going to get a randomized trial. And we, as the academics who treat lung cancer, need to figure out how we're going to do this, to figure out, should we be just doing adjuvant? Should we be doing neoadjuvant and nothing? Or should we be doing perioperative? And is there a way to help select? Because it gets more and more expensive as you go from 6 months to a year, and we don't know who's benefiting. And I've got one trial that looks like maybe there's a benefit to the additional immunotherapy in the people who don't achieve a pathologic complete response. I will tell you, this is going to be a really hard sell when they had a very cost-effective application for Checkmate 816 to come through CADA. When these folks come, you have to take it for face value of what it is. There is an improvement here, but when it comes to the health economics, I think it's going to be very tricksy to leap that bar for, why should our government pay for this additional benefit? I'm not saying that they shouldn't. I'm just saying that we've got a lot of questions to answer. So my last couple of slides here are going to be about how to actually come together as a team. And so I've actually given several of these talks across the country about how do you actually organize your multidisciplinary team to think about making decisions around this. And we did this when Pacific first came out. We did this when Checkmate 816 first came out, and we've done it again more recently as this data has evolved. So I think it's really important to set your ground rules. So we have sat down and we've talked about what is considered resectable. And we did that in the Pacific era. And now we're rethinking it in the perioperative treatment era. What are an acceptable timeline for initiating treatment? How long are we willing to wait for things like surgery, et cetera? And I think it's really important to engage patients. There's going to be some patients who absolutely are frightened to not just take the surgery and run with it, recognizing that they're at a disadvantage when it comes to receiving any adjuvant therapy. And there are other folks who will see the benefit and see that you're actually getting the full package by giving a neoadjuvant approach. Other things to think about, like this is what we now do day to day in clinic when our surgeons send us these patients. Do they have autoimmune diseases? Anybody have a transplant? What's their performance status look like? So we think about all of these types of things. Does PD-L1 status matter? Right now, we've agreed that we are learning. So I'm taking these folks, no matter how they want to send them to me. Part of my method to the madness, I talk patients through if they're PD-L1 negative, and I say, I don't know that you're going to benefit from this. At the end of the day, though, I know you benefit from platinum doublet. And so at the end of the day, I feel better knowing that they're getting platinum doublet in some way, shape, or form. And I'll tell you, in my practice, I'm often even giving that 4th dose of platinum up front so that they can be done in a PD-L1 negative patient population. So I don't have questions at the end of the day of, did I give enough systemic treatment? What about other biomarkers? So we are very strongly ensuring that all of our patients have a good next generation sequencing assay, despite the fact that it takes us a long time in Hamilton before we make these clinical decisions. So yes, they have to wait. Sadly, yes, they have to wait for an MRI of the brain. Yes, they have to wait for a PET scan. And yes, they have to wait for pathology. So pick your poison as to which one I'm waiting for to make these decisions. So I start talking them through things while they're finishing their staging. So pros and cons of the 2 different strategies. Pro, I honestly think it's a good thing to test biology. Do we honestly think that people who progress on neoadjuvant treatment were ever going to do well if they went straight to surgery? These people were probably destined to relapse. I say probably, I don't know that for sure, but maybe you can spare surgery to people who were honestly unlikely to benefit. 2, lymph nodes and their drainage are intact. I don't know how much of that paradigm applies, right? So if we give neoadjuvant chemotherapy, immunotherapy, and I start killing cancer cells, and you have all those very beautiful antigen presenting cells sitting in those draining lymph nodes, is having that drainage system intact important for establishing long-term immune response? We don't know the answer, but it makes biologic sense that maybe it's a smarter strategy to give these treatments in the neoadjuvant setting than the adjuvant setting. But again, I don't have a randomized trial to prove that. maybe we increase the likelihood of giving any systemic therapy. And I showed you earlier that Alchemist data that shows that barely 50% of patients in the US get any adjuvant treatment. In Canada, it's even worse, where it's about a third. And it is a short duration of treatment, right? Talking 3 or 4 cycles here until, 671 and a GN came around. Cons. There may be a missed opportunity, and I don't know if it's truly a missed opportunity or not, but it happens for 17 to 19% of patients, even in the chemo IO arms. They did not get definitive surgery. We do have better knowledge around stage and pathology that informs how they're going to do moving forward, but there are delays in initiating care. And right now, we still don't know what to do with these biomarkers. Like, we're getting a sense that maybe PD-L1 negative patients don't benefit, but we don't know that for sure. So here are my 3 take-home points from my talk today. 1, we are getting so much better treatment options for resectable lung cancer. Honestly, full knowledge of biomarkers such as driver mutations are going to be critically important. And I do use PD-L1 when I'm counseling patients about risk benefits. And then last but not least, multidisciplinary discussions to lay these ground rules are absolutely critical. We sat down with a whiteboard and actually wrote it out. 4 centimeters, node negative. What's our druthers around straight to surgery versus referral? And it was literally a patient-driven decision. You jump up to hilar node, might require a pneumonectomy. Stage 3, single station. Stage 3, not single station. What do we think we should do with them? And so we've boxed them all around. Our preference is Pacific. Our preference is neoadjuvant chemo IO. Our preference is straight up surgery. And I think it's really important to have these conversations, because otherwise you're not giving your care equitably. And you might have some surgeons practicing one way and some others. And unfortunately, in our world right now, surgeons are our general conduit for these things, and I can't control what they do. So if we can get the group together and actually talk about how we think we should practice and have some set of ground rules, I think it's critically helpful in establishing uniformity. And I think uniformity in healthcare is important. So I am going to stop there, and I'd like to thank everybody for their attention, and we'll take questions.
Thank you. Great presentation. I don't treat lung cancer, but I learned a lot today about changing paradigm. And maybe I'll start off with one question before asking the audience in the room and on Zoom as well. So do we have any rough idea about the current state of what patients in Canada are receiving, depending on the geographic location or institution? Is there more a consensus towards one, regimen versus the other, or is it scattered all across the board?
Great question. It's interesting, right? Because there's obviously centers in Canada that have participated in these trials, and they have truly drank the Kool-Aid. There are other places that don't have experience, right? And so this is why we sat down as a multidisciplinary group. We didn't participate in any of these trials. So this was new to us when this compassionate program came. And that's why we sat down and had multidisciplinary discussions. But at the end of the day, I've got keen surgeons. When I talk to my colleagues in some of the more, I don't want to say remote, but not at these big academic centers where they're used to dealing with the toughest of the tough cases, not all these surgeons are as keen, right? I gave rounds up in Sudbury, and the surgeons were like, you know what? I am just not convinced with stage 1 or 2 that it makes any sense for us to be schlepping these people over to medical oncology and then delaying their curative surgery. So I think there is a lot of conversation out there. I think there's also conversation on what the best chemo partners are. I was a little hesitant when I saw that gemcitabine was being used. Gemcitabine is known to be very lymphopenic, and I'm very worried that that treatment offers less benefit. And we saw that in the Empower 10 trial when people got 4 cycles of adjuvant followed by immunotherapy. The ones who got gemcitabine had less benefit. Maybe it's not the same when you're partnering it together as opposed to a sequential strategy. Don't know. I mean, Taxol Carbo looks safe, right? We've seen that in a couple of different trials. But one of the struggles is, we're starting to see, maybe cis is a wee bit better, right? That they showed that separate curves in the Keynote 671 trial that, again, cisplatin looks a little bit better, but it's a biased analysis, right? If I'm comfortable to give someone cisplatin, they're probably better performance status. They probably have fewer comorbidities. That's why I'm willing to give them cisplatin. If I'm giving carboplatin, you're probably older. You probably don't have perfect kidney function. You probably have a few other things that affects your survival in general and has nothing to do with my choice of drug. So there's a lot of decisions to be made. And like I said, that's why I think getting people together to have these conversations is critically important. Yeah.
Great talk.
Thanks.
My question is more along the lines of, is there data to address this question, or the higher level conversations, is there an interest in exploring? So radiation, not versus surgery, but for the role of chemotherapy, is either radiation or surgery in the stage 1 to 2 patients predictive of the benefit of chemotherapy or its role?
We are trying to answer that question now. So there is one of the Pacific trials that's being done looking at SBRT with immunotherapy, because historically, it's funny, right? I feel like the SBRT patients where we know that it's a good local approach, right? Like I'm not going to stand up here and get skewered by surgeons saying that it's equivalent to surgery, but in the right setting, SBRT is highly effective. The problem is we never give those people adjuvant because it's thought that, if you couldn't go to surgery, you probably wouldn't benefit from adjuvant. But that may not hold true from immunotherapy. So actually at our center, Anna Swamanath is planning a trial of that same paradigm of localized lung cancer, SBRT, and immunotherapy. I will tell him that you guys are curious because I think it's a multi-center trial. So if there might be interest in Kingston, I'll let him know to reach out. Andrew, how was soccer?
It was good. Yeah, I have to stop 7-year-old girls from socializing with each other.
That is my daughter playing softball, so I feel your pain.
Great talk, and in terms of that, we do have keynote 867 open, which is looking at the pembro versus placebo in that group. It's very difficult to find those types of patients.
Yep.
In terms of the stage 3, stage 2 neoadjuvant setting, you mentioned the adjuvant immunotherapy afterwards. I think in Canada, we're going to be really much more than the states able to approve, because I agree, I don't see people that are saying, well, let's just give an extra, $150,000 with no evidence or whatever it is. Are we waiting too much for industry to get that study done?
Industry's not, it is not in their vested interest to do it, Andrew, you know that, just like I do.
So we know it's going to be.
Yep.
So are we waiting too much for some sort of level of perfection, ctDNA and all that sort of stuff, or do we just get her done?
The problem is like I said, there's going to be zero appetite in the United States, right? They will not be able to randomize to that trial, I don't think reasonably, because these are all going to have indications in the US. The docs are going to be able to do this without a question. And so they're not going to be able to randomize. So it's going to fall on the back of Europe, us, rest of the world to figure it out. And that's the question is, does Canada bring it to the EORTC and say, let's partner? Australia, right? We've had great partnerships with them. I think somebody needs to figure it out. And I think we're all intimidated by that, that's a brutal consent, right? Like straight to surgery versus peri-op alone. It all
Leave the straight to surgery.
Yeah.
After neoadjuvant patients who've had surgery, randomizing to continue.
That's an easier trial to do because you could placebo control the entire bit of it if you were so inclined, right? And then we're still trying to figure out how much do you need, right? Metastatic setting, it's 2 years. The stage 3 setting, it's 1 year. The Europeans were it was interesting. So Nadim 1, which I didn't show you today, actually had a year of adjuvant. And based on their experience with that, they actually walked it back for Nadim 2 and decided 6 months. So none of us know how long do you need to do this. And when I talk to patients about the differences between the different systemic therapies, whether it's chemotherapy or immunotherapy, chemotherapy, you got to keep on task. If you don't keep it in the bloodstream, you're not going after rapidly dividing cells until they're all gone. And you have to do that for a certain period of time to get them all, right? 1 dose of chemo, it's like 1 dose of antibiotics. It just doesn't eradicate the problem. Immunotherapy is a different beast, so I describe actually the scenario of timers, right? So if I'm giving chemotherapy, it's like I go to a light switch, but it has a timer and I turn that timer on for 3 weeks, depending on the regimen. When the 3 weeks is up, the chemo is gone. And if there's any active cancer cells, they are free to play. With immunotherapy, it's like turning on a light switch. And every time I come to give another dose, whether it's every 3 weeks, every 4 weeks, every 6 weeks, I'm basically practicing with my OCD and just touching the light switch to make sure it's turned on. And we don't understand. Could I do this Q3 monthly? Do I have to do it every 3 weeks or 4 weeks or things like that? And I have no idea how we're going to answer those questions. But biologically, we don't necessarily have to keep these folks coming back to the cancer center and figuring these things through.
One more follow-up question. Sorry, real quick. You mentioned people surgery only half get chemotherapy.
Not, yeah,
Because
in
of
the
the-
US, not in Canada, yeah.
Because of the way it's done.
Yep.
There's drop off. So in the trials, in a trial population, 15-20% ever got surgery. So what? When you're implementing in practice, how are you gonna say in 2 years, we're gonna look back and see how many actually got surgery and how much of that? Because there's gonna be drop off either way.
So there are plans afoot through some of the database work that is happening. So there's a couple of different lung cancer Canadian lung cancer databases that are out there. There's one called KarmaBros, there's one called Paleos that are collecting data. I know that John Spicer is in cahoots trying to sort out potentially through CATS about creating a nationwide database that the medical oncologist would have to help support because they won't have access to all of our stuff with the precision that we think that we should be collecting it. But it sounds like there's plans through CATS to actually start collecting Canadian data on what happens to our patients as we start mucking with the paradigm.
So thank you so much. I'm sure we can go on much longer for more, questions about this great and interesting presentation. And we were delighted to have you here. And thank you so much.
Thank you for the invitation. It's been nice to be back.
The invitation to give us an update, which hopefully, I don't know, like how long those things will take to get the consensus.
Yeah, but like I said, it's been the biggest practice changing thing since immunotherapy came to metastatic disease. So
And that kind of, P16 and started, like looking at the differences, how long it took us to get on.
yes.